Welcome back to The Explainer. If you are a focused learner gearing up to completely master oral pathology for your boards, well, you are in exactly the right place. Today, we're taking what is honestly a pretty dense, overwhelming topic, oral white lesions, and we're transforming it into a highly structured, visual cheat sheet. We're going to break down the clinical characteristics, the etiology, and the management of these conditions so clearly that you will literally be visualizing this breakdown during your exam. Get ready to lock in those high-yield facts.
Okay, let's jump right into this with a classic board-style scenario. Imagine this. A patient presents with a white oral mucosal lesion. You take a piece of gauze, you rub it, and it absolutely does not come off. So what's your next move? This isn't just some hypothetical brain teaser. It's the foundational fork in the road for diagnosing oral pathology. By the end of this explainer, the exact diagnostic algorithm to answer this is going to be second nature to you.
Here is our ultimate study guide blueprint. We are kicking things off with the fundamentals of white lesions, then high-yield normal variants, moving into rubbable chemical and thermal burns, then non-rubbable frictional lesions, and finally, the high-risk lesions. Let's get right to it.
Section 1. Fundamentals of white lesions. The why.
So, why do we even see the mucosa as white in the first place? Well, the answer actually lies in the physics of light. Normally, oral mucosa is this translucent pink color because light passes right through the epithelium, hits the capillary bed, and reflects that healthy pink hue back to us. But white lesions? That happens when the light scatters. Looking at the fundamentals here, there are three key histological buzzwords responsible for this scattering that you need to burn into your memory. Number 1. Increased thickness of the oral epithelium, otherwise known as hyperkeratosis. Number 2. Intracellular edema of the prickle cells. And number 3, coagulation of surface tissue, which forms a pseudomembrane. Literally every white lesion we discussed today is going to fall into one of these three mechanisms.
Now look at how perfectly this clinical classification categorizes everything you need to know. Think of this as your ultimate exam matrix. Notice how we divide things up clinically. First, ask yourself, is it a normal variant? If it isn't, is it non-keratotic and rubbable, like a pseudomembranous burn? Or is it keratotic and non-rubbable? And hey, if it's non-rubbable, we have to make the absolute most important clinical distinction. Is it potentially malignant or not? Keep this matrix right in your mind's eye as we move forward.
All right, Section 2. High-yield normal variants. The tricky lookalikes.
Time for a rapid-fire differentiator. Examiners love using leukoedema and Fordyce's granules as distractors. The absolute golden rule to tell them apart? The stretching test. Leukoedema shows up as a bilateral, milky white, kind of wrinkled appearance on the buccal mucosa. But here's the kicker. It completely disappears when you stretch the cheek. Histologically, that's due to that intracellular edema of prickle cells we just talked about. On the flip side, Fordyce's granules are yellowish-white papules. When you stretch the mucosa there, they actually become accentuated. They pop out more. Why? Because they're ectopic sebaceous glands sitting just under the surface. So remember, disappears on stretch equals leukoedema. Accentuated on stretch equals Fordyce's.
Our third high-yield normal variant is one you've definitely seen, linea alba buccalis. This is just a bilateral, totally asymptomatic, slightly whitish linear elevation. It perfectly traces the occlusal line of the teeth right from the commissure back to the posterior teeth. The cause? Simple pressure or sucking trauma from the teeth rubbing against the cheek. No treatment needed whatsoever.
Section 3. Rubbable lesions, specifically chemical and thermal burns. Before I give away the answer, let's do a quick active recall checkpoint. If you rub a white lesion and it sloughs right off, what is the exact clinical and histological feature you are observing? You guessed it, it's coagulative tissue necrosis. This necrotic surface tissue mixes with inflammatory exudate to form what we call a pseudomembrane. Because it's literally just dead tissue sitting on top of an injury, it rubs off super easily. But definitely beware, when it does rub off, it leaves behind a red, raw, incredibly painful, and bleeding surface. And this breakdown brilliantly illustrates the most common chemical culprits you're going to see on the boards and in the clinic. Aspirin is an absolute classic. A patient has a toothache, and instead of swallowing the pill, they tuck the aspirin tablet directly against the mucosa, causing a severe focal burn. Ouch. Sodium hypochlorite is one you might accidentally cause yourself if this root canal irrigant splashes the mucosa. Silver nitrate, well, that used to be used to cauterize aphthous ulcers by destroying nerve endings, but it causes severe tissue necrosis, so we really shouldn't be using it. And even regular 3% hydrogen peroxide mouthwashes can cause epithelial necrosis if patients misuse them.
Now, there is one more chemical burn, but this one is internally generated, uremic stomatitis. This pathway is just fascinating. In patients with severe renal failure, their blood urea nitrogen, or BUN levels, skyrocket past 150 milligrams per deciliter. That causes elevated salivary urea. Then, oral microorganisms produce an enzyme called urea, which converts that salivary urea directly into ammonia. That localized spike in ammonia essentially causes a direct chemical burn right on the tongue. So how do we actually manage these chemical and thermal burns? Well, step 1 is always prevention. Use those rubber dams during endo. But if an accident does happen, immediately flush the area with lots of water. Step 2 is stopping whatever habit or chemical caused it, and then managing the pain. We usually do this with topical steroids, like 0.1% triamcinolone paste or a topical lidocaine gel to keep the patient comfortable. Step 3 is just giving it time. Most of these superficial burns heal beautifully within 1 to 2 weeks once that irritant is gone.
Moving on to Section 4, non-rubbable lesions, looking at frictional and habitual causes. Let's compare two trauma-induced lesions that are closely related. Frictional keratosis is a reversible white plaque caused by obvious mechanical trauma. Think of a rough denture flange rubbing the gums or a sharp, broken tooth cusp. Histologically, it's just hyperkeratosis, literally the body building up a callus to protect itself. File down that sharp edge, and it resolves in 2 weeks. Then, on the other side, we have morsicatio buccarum, which is just a fancy term for chronic cheek biting. The ultimate board buzzword for this is a frayed presentation with small tags of torn tissue mixed with some redness. To fix this, you have to break the habit, which often means prescribing an occlusal night guard.
Now here's a quick, high-yield occupational footnote: glassblower's keratosis. As the name suggests, this affects the labial and buccal mucosa of folks working with molten glass. What's crucial to remember for exams is that this hyperkeratosis is triggered strictly by the intense heat radiating into the mouth, not by any chemicals. And it's entirely reversible if they happen to change professions or their glassblowing habits.
Finally, Section 5, the high-risk stuff: tobacco, actinic, and infectious lesions.
We've got to start with nicotinic stomatitis. This shows up on the hard and soft palate of heavy pipe, cigar, and cigarette smokers. The clinical presentation is super specific. The palate gets highly hyperkeratotic and white, but it's studded with these elevated white papules that have very distinct red centers. And those red centers? They're actually the inflamed orifices of the minor salivary glands reacting to the intense, concentrated heat of the smoke. Let's group the essential facts for smoking-related keratosis. Regular smoker's keratosis appears as a diffuse, milky white lesion right where saliva pools, usually in the lower cheeks and vestibules. This is driven by both the heat and the toxic tobacco constituents, like nitrosonor nicotine, or NNN. Histologically, nicotinic stomatitis shows acanthosis and those inflamed minor salivary glands we just mentioned. But there's good news. Both are usually reversible within 2 to 4 weeks of quitting smoking. In fact, nicotinic stomatitis rarely turns malignant. But there is one major geographical exception. Individuals who practice reverse smoking, where they place the burning end inside the mouth, have a significantly high risk of malignancy. Now let's look at a different habit entirely: smokeless tobacco keratosis, sometimes called snuff dipper's keratosis. Because users tuck the chewing tobacco directly against their gums, the classic presentation here is a granular or deeply wrinkled white lesion sitting right in the anterior or posterior mandibular vestibule. You are also almost always going to see localized gingival recession and severe tooth discoloration exactly in the spot where the tobacco sits.
So what is the crucial point here? It's the whisk associated with smokeless tobacco. Histologically, we see parakeratosis and epithelial hyperplasia, but long-term use frequently leads to dysplasia and malignant transformation because those tissues are just bathing in carcinogens like NNN. The treatment rule here is strict: complete cessation of the habit. If that wrinkled lesion remains after 1 month of quitting, or if you ever see ulceration or red patches mixed in, you absolutely must perform a biopsy to check for carcinoma.
Rounding out our high-risk lesions are two very distinct conditions. First up, actinic or solar keratosis. This is sun damage, classically found on the lower lip vermilion border of outdoor workers. It looks like a crusted, rough, ulcerated white plaque. It is potentially malignant and requires PBS sunscreen for prevention, plus a biopsy if you feel any induration. Second is syphilitic keratosis. During the active secondary stage of syphilis, high concentrations of spirochetes cause atrophy of the tongue's papillae. By the tertiary stage, This smooth, atrophic dorsal tongue surface reacts to even minor irritation by forming hyperkeratotic lesions. And yes, these too carry a really high risk of transforming into dorsal tongue carcinoma.
Look at how far we've come. You now know exactly why the mucosa turns white. You can spot the normal variants that try to trick you. You know that if a lesion rubs off, you're dealing with a pseudomembrane from a burn. And if it doesn't rub off, you can figure out whether it's simple friction or a high-risk keratosis demanding a biopsy. You have officially mastered the matrix. Now, if any of this felt a little fast, bookmark this explainer, run through the cheat sheet one more time, and you are going to be absolutely unstoppable on your exams. Keep studying hard, and I'll see you in the next explainer.